I've worked with this company for quite a while. MicroPulse isn't a brand new therapy. It's been kicking around the woods for quite some time. And we're going to talk about some of the basic ideas about how it's actually working, because it's hard to believe that something that you can't see is actually doing anything. Does the emperor have clothes or does he not? So we're gonna kind of talk about some of the evidence-based ideas on how MicroPulse therapy is working. There is still a lot that is not known, but there's a lot that we're going to know with these clinical trials coming up. So a lot of the experience that we're going to talk about is certainly not level 1 information, but it's pretty good suggestive information that we have something that's doing a lot of good. So I would like this to be informal, interrupt at any time.
Can't really get any more informal.
And that's it. That's it. Just shout out. Do not wait till the end and store up questions. Just
Stuart and I, we share a latrine together and sort of share
there you go. There you go. So the backdrop is that we have an epidemic going on of diabetic cases. Even in this room, by 2020, 1 out of 6.5 people is going to have diabetes. So the chances are that someone has it in this room. All right. So it is pretty much out of control. All of us are kind of familiar with many of the talking points on diabetes. That it's a late symptom, that we're treating things from different practices that are often late in the course when vision loss has already happened. So we inject and we inject and we inject, and we're always trying to play catch up. So the history of this is that laser has always been the mainstay of treatment until the anti-VEGF era came in. And I want you to understand that MicroPulse therapy, even though it's invisible, works exactly like the thermal laser did before. It actually has the same biochemical profile that is elicited, but with no damage, that the thermal laser actually did. So that is something I'm going to try to convince you that is playing out in all of this. And so we've always treated focal therapy, and I don't think the thermal laser needs to be thrown out of the practice. I think if it's circinate rings and you can see some microaneurysms, have at it. And you can probably do some pretty good job there, and you got better than a 50-50 chance of coming out of that unscathed and patient doing pretty well. But it's really this concept of the edema that actually now spreads into the center part, and really what is the best management of that. So in the old days, I can still remember as a resident just getting excited as heck and picking out those little aneurysm, hitting them. I do think this is a little hot. This is not what I would call a gold standard sort of slide, but 3 months later you don't see the burns and life gets good and things go away. But the bottom line is nobody got better. Very few people actually had dramatic improvement of 3 lines of visual gain. So it as a treatment has always confounded things, because even when you go to the DRCR sort of studies and compare injections with prompt laser versus deferred lasers, the laser really doesn't add a whole lot to the whole story. It never really had the big pompous visual gains that we were actually expecting by combining therapies. And so there's something about thermal lasers that need to be discussed. And is thermal laser really causing laser expansions that's causing a little bit abnormal visual results, or is it the fact that we're treating in big grid patterns that are damaging some of the nerve fiber layers? What is it that's actually going on? And we still don't know the answer to that. So things moved into the VEGF sort of thing. And the bottom line that always has troubled me is this chronic treatment that's needed, because there is no loading dose that anybody can discern with these anti-VEGF therapies. I don't care who's talking on the podium. There does not appear to be a loading dose like what happens in AMD or vein occlusions. Those clearly have a loading dose and then you maintain. But this just looks like it goes on forever. It's just infinitesimal sort of gains, that the longer you treat, the more vision gains they got. And so nobody gives 3 years of 36-month treatments. Nobody's doing that. And we also know that lasers, once again, really don't do much in terms of improving the vision. And if you wait too long, you don't get the gains either. So there's some issues that, as a backdrop of how can we reduce this sort of curve so that this sort of long drawn-out vision gain is somehow shifted to the left. Can we shift the curve to the left where less injections are needed, and we can achieve perhaps a more sustainable paradigm for engaging patients? I need to push this one right here. So the continuous wave lasers differ from the MicroPulse in a major fashion. In the continuous wave, we control power and we control time, but the laser is on for whatever time that you actually pick. And so that creates a thermal gain that has a tissue effect that you can visibly see. That was our endpoint. Whatever you see, and you felt comfortable with that. You knew you could turn it down, you could turn it up, you thought you had some sort of control. What MicroPulse does is it wraps that same duration of on switch, but it pulses it, what we call a duty cycle. So the reason that you get very little thermal gain is we can put it at a 5% duty cycle, which doesn't produce any visible tissue damage that we can actually visualize. And so that's kind of uncomforting because we're never sure, was it enough? Did we have the settings right? You know, what's going to actually happen? So we'll talk a little bit about that, that comfort.
You may already go into it, in which case
yeah.
disregard my question, but you can talk about a little bit about what you actually think you're doing with laser, whether it's continuous or pulse in terms of stimulating which factors.
Yeah, we're good. That's right. Coming right up next, buddy. Right up next here. So this is an example of a doctor from Japan, in Agagi, who actually took a tissue culture plate of human RPE cells and lasered them with continuous wave laser on one hand and a MicroPulse laser on the other. Now, the difference between these two is they use the same amount of power, 90 millijoules of energy, okay, but they achieve it with a different way. One is with a MicroPulse duration, where it's a 15% duty cycle. I do not recommend 15%, and I'll show you why histologically, why we don't recommend that much. But notice that what happens is they've stained these cells, and red is dead cells, okay? And so every time you see red on this is the area of thermal necrosis from a continuous wave laser on that plate. And then you get a surrounding zone of sublethal damage. And in histological sections, that sublethal damage is why laser scars expand. That's why you get a twofold expansion of laser scars over the next couple of years. So dead cells are seen with the continuous wave in the center. At 15% duty cycle, no dead cells are seen. Now you can see a tissue reaction. Obviously those cells were affected by that 15% duty cycle, but there are no dead cells within that laser spot. If you stain now for heat shock protein, you'll see that the reason thermal laser actually works is not from killing off cells in here, it's from this sublethal effect where you have a little less damage and you still have viable tissue, and that's where the heat shock protein is actually being produced. But notice in the MicroPulse thing, same amount of tissue that was treated, you have the same heat shock protein being produced. Now, heat shock protein is one of those stress-related proteins that actually helps to protect cells. It helps in the immunological regulations. It may even have some definite benefit in actually resolution of macular edema. But each laser-treated tissue has the same protein being expressed. And so that's why I can say that there is evidence that the same biochemical, and there's even more that we'll talk about in just a minute, but the same biochemical effect is produced by burns that you can see and burns that you can't see. Okay? So I would say emphatically that MicroPulse laser works similarly without producing tissue damage, but biochemically similar as the thermal laser that we're all much more familiar with. Now, if you actually look at the amount of damage, this has a large area of tissue necrosis right here in the center. No areas of tissue necrosis is seen here. The time frame for producing of these heat shock proteins is pretty similar, 2 to 3 hours roughly between the two types. And so we end up with the effect that within a very short order after giving MicroPulse to human RPE cells, we can see heat shock protein being produced, and it peaks right around 3 hours. Using the same amount of energy, there's very little tissue damage with the MicroPulse, and I don't recommend, once again, 15%, but it is the experiment that he actually did.
So Larry, quick question, just in terms of, I mean, these are human tissue RP, sheets that you guys are treating.
I'll show you some animals.
So the histology of the outer retina is
That's what I'm going to show you that. I'm going to show you that in just 1 second. And that the area of damage is markedly reduced by using the MicroPulse laser. So that's part of the backdrop of how this thing works, and I'm going to show you some histology in just a minute. From a human standpoint, Vujocevic has produced an interesting paper clear back in 2010 where he enrolled patients that got grid laser therapy in standard continuous wave treatment and compared them to MicroPulse treatment. Now, there's 62 eyes of 50 patients that had clinically significant macular edema involving the center. They used the red MicroPulse laser, and I don't think it matters whether you use red, yellow. I like the yellow. That's what I think is the best, but I've actually used the red for a number of years before. And these are the results that happen at the pre-treatment and 1 year later in the thermal, and the pre-treatment and 1 year later in the MicroPulse. And they did two interesting analyses. One was using microperimetry, and you can see that in this particular patient, red and anybody use microperimetry? You guys use it? Well, it's pretty simple, Stuart. Red is bad, yellow's a little better, and green is really good. Okay, so clearly has a large area of even though it has a center involving CME, which you can see on the OCT, you have very little damage. When you treat with the laser, there's more red spots now and a lot more yellow that appear 1 year later. And if you look at the autofluorescence, you can see now the laser spots that actually pop up here, but resolution of the edema is achieved. Okay, so the thermal laser works just like we predicted. If you look now at the MicroPulse, here you have a patient that has some areas of mild microperimetry damage. Post MicroPulse laser, it actually has an enhancement. There's actually even more green. Some of the yellow drops out. The edema resolves, just like it did over here. But when you do autofluorescence, there is no footprints. 1 year later, there is absolutely no footprints that were detectable. So it looks like you can deliver MicroPulse and clinically get a clinical effect, much like the thermal continuous wave lasers that we're much more familiar with.
I'm just here to learn stuff, but I'm just trying to figure out. So is the idea that the MicroPulse, even though it's the same amount of joules, but because of the duty cycle, you're letting the choriocapillaris act as a heat sink, so you're not getting thermal injury?
Well, it never builds up very high either.
But because the choriocapillaris is shunting away the pulses?
Well, it is a short pulse, one, so it never, if you notice even on the continuous wave, it takes a little while. It takes a whole 0.1 seconds to actually get that little peak up there. But the pulses are so short that it's just a little start to rise and then it dissipates real quickly.
It's the same amount of energy, so that if there wasn't some kind of heat dissipation by some type of heat,
I think that's part of the story. Yeah, I think that's part of the story. So this is your histology that you're asking. And so what happens with threshold lasers? You get a full thickness burn. This is barely visible at a 40% duty cycle. It's a barely visible sort of burn. But notice that there's tissue damage, not only to the photoreceptors, the RPE is clinically damaged. At 20%, you see nothing. I'm telling you, you can't see anything, and yet at 20%, there is damage to photoreceptors and RPE. At 10%, this isn't normal. You'll see the RPE, there's little skipped areas in between here. Photoreceptors look pretty good, but even at 10%, you can't see this burn, but there's still histological damage. This is a rabbit eye. And at 5%, which is what most of us use now, it looks pretty pristine. It looks pretty darn safe. Okay, so anyway, 5% doesn't appear to have any thing, but I want to emphasize this. MicroPulse laser by IRIDEX is different than subthreshold continuous wave, because subthreshold is somewhere between here to here that you don't see the burn, but you're still doing tissue damage. You're still doing tissue damage. So I want to make that point clear. MicroPulse is a proprietary name that has a certain technology of pulsing this that really doesn't build up heat at the right duty cycle.
Inflammatory cells on the 5% duty cycle, I mean, what are those cells that you see? Is that just normal?
This is RPE.
No, underneath it. So in the choriocapillaris, what do you?
Oh, this stuff here?
Is that the side of the
Yeah, because even at the high burns, I don't see that. I don't know. That's a larger choroidal vessel, I think. Yeah.
Cells coming in, and you guys must have all kinds
We didn't see any. We actually didn't see any. All right. So you asked about other factors. So there are a whole host of other factors that have been produced with thermal lasers: pigment epithelial-derived growth factor, thrombospondin 1, the stromal-derived factor 1, which kind of recruits mesenchymal stem cells to help remodel. So these are very anti-VEGF agents that are right up here. This actually has more healing sort of factors, and then beta-actin is kind of a structural integrity molecule. And all of these are upregulated not only with the thermal laser, but the MicroPulse also has been demonstrated to upregulate these. So in the past, we have been used to spacing continuous wave burns, at least a burn width apart. We kind of understand this low versus high intensity continuous wave burns. And I spent a whole year using MicroPulse wrong, because I went back to this sort of idea and was hunting and pecking with MicroPulse laser. It does not work. It does not work. Okay, I got miserable results, and I parked that MicroPulse for a while before I started reading up more and more and more. And I think Giorgio Noren and Luttrell actually wrote a nice little paper that actually showed that what you really need to get the right response of the factors is you need this low intensity burns but high density MicroPulse therapy. You have to contiguously put these side by side. When you do that, the effective area of producing the biochemical response in the tissue is markedly enhanced. Look at the amount of tissue that's producing endogenous anti-VEGF factors compared to this. This only has the edge effect right around the areas of thermal necrosis. Okay, so you add up all this, and it's a lot less than this. So the MicroPulse has an area effect that is critical to its ability to work. The one thing that I've just gotten this little gadget here. This gives you a little raster pattern. This makes your job easy because it has a 7x7 matrix, and you can just connect those little boxes and get this done in a fraction of the time. So you just put it. The patients tolerate it very well. It just does a nice little pattern. You just move on through, and your treatment is continuous. So what's the difference between modified ETDRS, which we know works for that, and low density versus high density MicroPulse therapy? And the low density means you're hunting and pecking. And notice that in the thermal, where you got 126 microns of tissue shrinkage, this over here only had a very minimal clinical effect. But the MicroPulse not only has equivalent amount of edema resolution, but you gain vision.
This is over what period of time?
This I don't recall what this was. This was, I think, a year. I think this was
almost
about a
after
year.
treatment.
Yeah. Yeah.
Without associated other steroid, I don't recall.
Yeah, no, this was MicroPulse alone. MicroPulse alone. Okay? So clearly, you have to use high-density treatments to actually get the clinical effect. So we were interested in a set of data that we produced ourselves, asking the question, could you combine MicroPulse laser with anti-VEGF treatments and effectively get a reduction in the treatment burden? Okay? And we were kind of tired of all these injections that were going on and thought that this actually might have a synergistic effect. So this was a retrospective study. We had one group of patients that got Lucentis only, in 19 patients, that were matched with a group of patients that got MicroPulse with other anti-VEGF agents. Okay? And the interesting thing about this group of patients is they had to have subfoveal DME, and they had to have, all of these patients that were combined with MicroPulse had no prior laser treatment. All these patients, no lasers were done. That's why we only ended up with 19 in each group, because a lot of people had had lasers in the past. They could have no steroid injections and no other concomitant disease that would be a confounder in any of this stuff. So what parameters did we use? It turns out that this has been used by a large number of clinical trials as a set of parameters that works for the overwhelming majority of patients. So we didn't even titrate this, although we always did a test spot. Okay, so we would do a test spot, and especially you might want to reduce this power setting of 400 if it's an African American patient or a darkly pigmented patient. You want to maybe reduce it slightly, maybe to 350 to 300 sort of, but you do a test spot to make sure you're not getting this. So the way we treated these patients, the anti-VEGF patients got the standard injection protocol. On the combination ones, 12 of the 19 patients had the MicroPulse initially, followed by anti-VEGF as needed. We would see them monthly and give them. And 7 of the patients had 1 to 3 anti-VEGF agents before because they had very thick OCTs, the 450, 480s, and we wanted to get them closer to the 400 mark before we actually did the MicroPulse. So that 7 of the patients had 1 to 3 anti-VEGF agents before, and we added up all these injections. That was part of the analysis. The parameters of the two is they're very similar. The only difference has to do in terms of follow-up with 19 to 20, almost 2 years. The MicroPulse group, because they had thinner retinas, there is a statistically significant difference between the enrollment of those points based upon not only the vision was different, but also that. But I'll show you how we analyze this, and you'll see the slopes of the curve is exactly the same in the two groups. And so what actually happened? If you look at the visual acuity effects, this is the control group, which we call the injections, and this shows you that the vision gradually improved over the duration of the final treatment. And there's not much of a difference in the slope between the MicroPulse and anti-VEGF group and this group. So we didn't think there was enough of a difference in terms of the final visual acuity change between the starting and the ending. And neither did we see a difference in the final thickness. That we thought that the thickness between the two had. So structurally and functionally, we thought the two groups were compatible. But what the real difference between the two groups had to do with the amount of VEGF injections. And so at 12 months, we had close to 6 injections with the injection group over the course of a year, whereas we were approaching 2 with the combination. And at the final, between 19 and 24 months difference, you'll see that there's almost really a 70% reduction in the amount of anti-VEGF treatments that we had to give to actually push these patients to the same functional and anatomic endpoints. And so this was an example of a person who got Lucentis and the MicroPulse, and at the This patient here had 2 Lucentis injections over I think this was a year time. And you'll see that there's a marked improvement in stability, and even the visual acuity went from 20/50 to 20/25. So yeah, 12 months, and this had a total of 2 injections with 1 MicroPulse treatment. So the frequency of the anti-VEGF agents was significantly reduced in patients who had the MicroPulse laser, which was significantly different. But I didn't see a major difference between the anatomical and functional results, which I didn't really expect to actually. And so this study has been the impetus to actually try to see if we can reproduce this now in a randomized prospective trial. It is daunting when you can't see a visible burn to know if you're doing anything. There's always this doubt in your mind, did you do something wrong? Is this not doing it? So there's a tenacity to probably undertreat at first. I would caution you that you have to use this low intensity but high density sort of treatment. They have to be a bunch of contiguous burns, and I would encourage you to try that Texcel 7x7 grid pattern. It really simplifies the application of this. Patients like it. There's no doubt that you're not going over the same line that you just got through treating. Okay? Yeah, it's faster. It clearly is. I think you have to have some patience with this. It typically takes, I tell patients 2 to 3 months if I'm just anticipating using MicroPulse alone. I don't see that rapid gain the first month that you sometimes see with anti-VEGF, where you're seeing a response. So it is slow. It can be safely repeated every 3 months. There are lots of, I'll show you a few slides here that show you can repeat it every 3 months. And once again, if you've done 4 or 5 of these and you go back and do fundus autofluorescence, you still don't see spots. So repeated dosing doesn't seem to do that. It's painless, so it's pretty easy to do that. Even when you don't see a marked reduction in the edema, there are visual gains that patients do document on their testing. So I'm not sure how to explain that, but it is a nice effect. And I do like this early treatment idea a lot, because I do think we can maybe hopefully prevent people from actually going on to needing some of these. So I think what we have is a safe laser. I think histologically it looks pretty darn safe. I like the compactness of this laser. It doesn't take up a whole lot of space. You can still use the slit lamp in your lanes, even continuously hooked up. You can still move through the day with this. There are lots of case series data now that's accumulated. What we don't have is a randomized prospective trial, but that's on the way. There is hope on the way here. So I do think we can verify some of these in a more scientifically conducive manner. I do think, I'm pretty convinced that the anti-VEGF treatment burden can be reduced with concomitant therapy with the MicroPulse. And I think this clearly expands the way lasers are still making their way through, and by golly, it seems, even though we're not seeing burns, it seems to work just as in the same fashion that the old lasers that we're very familiar with seem to work. So I'm just going to go through a couple of cases here that was pretty interesting. This is not my case. It's somebody from Colombia that is a 62-year-old male with center-involving DME that 5 weeks, now this is an exception to the rule. I don't think this is to be expected, but it does show you that with a MicroPulse laser treatment, even within just 5 weeks following a treatment, this has subretinal fluid, it has CME, that they got pretty good resolution within 5 weeks. Pretty impressive case, and certainly not what I would call a classic response, but an outstanding response in this particular case. Here's an example from Italy. of a patient who actually received 3 MicroPulse treatments over a 2.5-year period for center-involving DME, and 2.5 months later, or 2.5 years later, had a pretty solid structural anatomical result with an excellent visual outcome. So from an OCT standpoint, this isn't autofluorescence or anything, but you don't see overt RPE or photoreceptor damage in this. Here's a case from Mayron in New York, who a 77-year-old male with center-involving DME who had 4 MicroPulse treatments, and 17 months later had this anatomical appearance where this was the pre-treatment. And notice on the fundus autofluorescence after 4 treatments, there's just nothing that you can see but a good structural anatomic outcome. So I'm telling you, you can do multiple treatments and do pretty well with this. This is a little interesting. Lucentis is actually published on this using MicroPulse therapy in, you know, you get these nets that have chronic subretinal fluid, and you kind of wonder if they're just got a resistant sort of state or what's going on with this. So here's a case that received 2 years of anti-VEGF therapy with chronic subretinal fluid, received 1 MicroPulse treatment, and the fluid just went away. Lucentis would argue that somehow the MicroPulse is sensitizing the RPE or making the retina more sensitive to the anti-VEGF therapies. That's the hypothesis. Now, people haven't been able to reproduce this yet, but it is an interesting idea that needs to be probably looked at a little bit more, because all of us have patients like this that are just perking along.
Oh, this was a CSR patient that responded to MicroPulse.
Well, that's always the big question. That's the big question. But so speaking of central serous, that certainly does work for central serous. Here's a 29-year-old female, 8 weeks pregnant, bilateral central serous, large domes, who 9 months post treatment, it actually works. So kind of I've used this a fair amount. It actually is a pretty gratifying way of treating it, and I don't have any problems treating through
What's the time frame?
the entire fovea. We don't know if this has been around, so this is obviously, by the time somebody treats it, they've usually given it a 3 to 4 month.
We're eating your food.
Yeah. So
Next one.
so it's. Thank you.